good. Go.
All right, so for Dr. Frazier's patients, he does a direct anterior, mainly with his patients. He will do a posterior lateral approach at times. So just look up the brief note from his PA, wherever the PA is that day. It will say direct anterior, or his op note. It will say direct anterior or posterior lateral. The posterior lateral will have posterior precautions. That's what I gave the handout on. Of the no bending past 90, no turning your leg inward, and then no crossing your legs. But the direct anterior has no true precautions for that. They typically are all weight bearing is tolerated too. So his anesthesia can be general or it can be spinal. You need to just be aware of that too, about getting them up too early if they're not thawed out yet. So that's a big thing that we see too. So hopefully by the time we see them, they're already good, and then we go from there. Okay. I don't know if we would see a non-weight bearing or partial weight bearing as a same day anyway, so that doesn't really make, so just be aware that if they're toe touch weight bearing or non-weight bearing, just give us a call, we'll go see them first, and we can kind of go from there too, just to make sure they're okay. All right, so direct anterior approach, again, no true precautions, okay, they can move. Posterior precautions with his posterior lateral approach, his traditional ones, the handouts are there for you to kind of look at too. Okay. All right. Let's go. So typically, what I prefer for them to use is a walker for the first time getting up, so they're safe. We can see them with crutches on the second day. It just for safety concerns, and just getting more stability. The walker will provide you all that. So I'll use the walker right here. So height-wise, the traditional textbook is just on the kind of the wrist of the crease right there, so right here, and you can have them supported like that. Once they're up, you want them to put their hands on the rail. Sometimes they'll lean forward too far, or they'll lean like here. You want it on the rail here. That provides you the most support, and then they can initiate the movement with their surgical limb first and kind of feel it out as they move. This is no different than what we do with anybody else, but just that's how I kind of teach them to go, and then they usually are okay moving that way. Okay. Questions with that? Let's do some patient handling.
What am I?
You're going to be a hip. Left. Okay. So those rooms that we're seeing mostly in the back rooms, it's a little bit tighter. So let's say it's his left hip. Typically what I would do for the first time them getting them up first is I'd have the head of the bed up a little bit to make it easier for them just to get them up and just get them some kind of confidence with moving. I make the legs as flat as I can. For the knees, we want the bed to be locked out in the legs. Okay. So typically, when I have a patient start mobilizing, I'll go away from I'll go on the strong side first. So you move your right leg over, and then I guide them over with their left leg as they scooch over. I go above the knee, above the ankle as they come to right here, and then I have them scooch forward to right here. Once they're here, we can kind of establish where they are symptom-wise, and we go from there. It's really hard for a patient just to lift up their surgical leg and just bring it over. It's uncomfortable. They're not going to like it typically. I'd rather them be comfortable first for the first time than just having them try to do it on their own and get snagged in the bed. So once they're here, gait belt obviously around the waist. Walker's here, one hand on the bed, one hand on the walker, and they can load up. I just usually tell them, your weight bearing is tall right here, you can put whatever weight you want on your leg, and they stand up right here, bring your left leg back, and then over here. Once they're here, the steps you want to take, you're going to be the walker forward, taking this first step with your surgical leg. That tells you everything. If they can step and load like that, you're good. They can move. If they step and kind of buckle or step and have a lot of pain, that's kind of your cue. Maybe we should get a commode or just maybe just a pivot transfer for right now. If they're lightheaded or dizzy. Okay. Perfect. Total knees is no different how I move them. I move them above their knee and above their ankle to get in the edge of the bed, and then they can kind of slide their heel back and forth and go from there. Okay? Questions with that? Makes sense. Okay.
The bathroom's on the right side where you're standing and it's a right hip, is it just the same thing? Swinging it over while they swing their
You can
leg?
just help them. You can help
Okay,
them.
just making sure.
Yeah, you can help them. Especially in those rooms, I just kind of push the bed a little so I have more room. And I just take them back. That's what I typically do. When they sit or when they stand, typically what I tell them to do is before they sit, let's say it's the left hip again or left knee, just bring out that leg before they sit no matter which way it is. It's just less pressure in the front for direct anterior as you maintain your precautions with posterior. With the knee, the same thing. If you sit down like this with a total knee right onto it, it's gonna hurt. So you just wanna stagger out a little bit. You're still bending your knee. You're not doing anything different. Just more for patient comfort and patient kind of just confidence in moving like that. It's always a stagger out. They like it better.
And something that kind of helps, like the knee patients, let's say I have a left knee, when they're getting back into bed, is if you have their good leg underneath the, like right here, and then they can kind of do that number, just less stress on the knee.
The hardest part for them, even the hip or knee, is getting back to bed against gravity. So if they can't even do that, then I just help them back to bed.
Yeah.
And then usually I teach the coach the same thing too. Until they're able to do it on their own, they're strong enough or their pain's managed enough, I usually help them with that. I don't want them to set their pain off for the first time moving. They'll be less apprehensive to move again. So it's all about patient comfort.